want to thank everybody for being here today. That's awesome, and I want to thank our online audience as well. We had over 300 people register to be on today's program virtually from around the world, all right? And that's a great number. You hopefully made it to the exhibit room, and if you did, I just want to let you know that we had platinum sponsors today for this program from Bristol-Myers Squibb, Biogen, and Sandoz. Our silver sponsor was Memorial Regional Hospital, and our community sponsors are Sanofi, Alexion, Janssen, TG Therapeutics, and Horizon. Let's give them a round of applause. Also exhibiting, we have Acorda, Banner, EMD, Serono, Genentech, and Novartis. Thank you to them as well. All these companies recognize the value of the programs that we've been providing, and that's been very, very important, because without them, we couldn't be doing the programs, and without you all, we could not be doing the programs. I wanted to recognize two people that are in the audience. One actually is not here right now. Maria, you here yet? Maria is here, great. And is that Maria Z? Yeah, you are here, great, okay, perfect. So for everybody online, you can't see, but you just have to listen to what I'm about to say. We have Mr. Michael Mayette. Michael, raise your hand. Everybody see Michael? Michael has been a self-help group leader, a support group leader for the National MS Society for, I don't know, way more than 20 years. Let's give Michael a round of applause. I know that Michael's doing it from that long ago, because when I was first diagnosed in 1998, his was the first group I attended. And it meant a lot to see what he was doing for the National MS Society, and he's the reason, he was the catalyst for me to be doing the things that I do. So I want to thank you personally for that. Thank you. And Michael, it's wrapped in bubble wrap, and I'm going to need your wife to come up and get this, but this is a plaque for you to show the recognition that we are giving you for what you do for the people with multiple sclerosis. Maybe we could take a picture of him. Hey, somebody take a picture of Michael with holding the plaque, all right? All right, next, Maria Zaldivar. Maria has been running a group in Miami for over 10 years. And I know that very well because I and two other women were co-facilitators of that group for more than 10 years. And when we stepped down, Maria took over. So I want to thank Maria also for all the work that she's doing for the MS community, especially down in Miami, where there are no other support groups for people to get the help that they need. And so Maria, if you don't mind coming up, this is for you, and thank you very much. All right, cameras, can you see it? Zoom on in, there you go. That's what Maria's getting. Okay, perfect, thank you. Our speaker is not here. Okay, this is where we're gonna get into some of the virtual aspects, all right? So this next presenter of ours happens to be in or around Columbus, Ohio, and her name is CARINA SIRACUSA. She's Dr. CARINA SIRACUSA, and I don't wanna mess anything up about her. She has spoken at many of our events. She will be online in a moment for you to see. Dr. CARINA SIRACUSA has been a practicing physical therapist since she graduated from Ohio University with her doctorate in physical therapy in 2005. She has practiced in the areas of pediatric, neurologic, oncologic, and pelvic floor therapy in her tenure as a physical therapist. She currently works in the neurologic rehab department at Ohio Health in Columbus, Ohio, seeing patients of all ages, abilities with pelvic floor dysfunction. Now, we know that this has a lot to do with the ladies out there, all right? But guys, listen in on it. You may know somebody that this will affect, and I think some of what CARINA's going to speak about affects men as well. So let's let CARINA take it away.
I'm here to talk to you all about pelvic floor physical therapy, what it is, and why it may it may help you with some of the symptoms that you are experiencing with your MS. So as Stuart said, I practice in Columbus, Ohio, with a company called Ohio Health. It's a hospital-based system, and I practice in their neuro space. So I treat primarily people with neuro issues for their pelvic floor disorders, and it does affect women and men. While there is kind of this idea that women do have more pelvic floor disorders than men do just because they have babies, MS does not discriminate when it comes to bowel and bladder issues. So everybody can experience them, women at just a slightly higher rate than men. So we'll go ahead and get started by first looking at the pelvic floor muscles. So what you can see on this slide is your pelvic floor muscles. And it's your pelvic floor muscles are a little bit different than some of the other muscles in your body in that they are kind of shaped like a bowl. So as you can see from this picture, they run from your sit bone, from either side of your sit bones, and your pubic bone to your tailbone. And you'll also see in this picture that there are some holes there. So we have openings for our urethra, in women, the vagina, and in men, the anus, and everybody has an anus. Excuse me. You'll see that's the great equalizer, is that everybody poops, right? But you'll see those holes there. And you'll see that they are, that's where everything comes out. So during, when we're pooping and peeing, those muscles are actually relaxing. So moving on to the next slide. So this is the difference between a male pelvic floor and a female pelvic floor. So a male pelvic floor, you can see, is just a little bit different. Main difference is that there's only 2 holes instead of 3 holes. And the muscles are oriented just a little bit differently than in a female pelvic floor. As I said at the very beginning, one of the reasons why women tend to have more issues with their pelvic floors than men is that a baby comes out of that hole, so an object much larger than that hole ends up coming out, stretches the muscles out a little bit. But men can have issues with their pelvic floor as well, because they can have surgeries like a prostatectomy or have prostate problems, and this can cause issues with the pelvic floor. Also, as I said, everybody has an anus, and so if you have something like chronic constipation, then you can stretch out those pelvic floor muscles in just the same way, because you can see on both pictures kind of how much muscle there is. So pushing out and constantly having to push stool is going to cause some pelvic floor muscle dysfunction. So let's specifically start to talk about, we're going to talk about bladder complications, bowel complications, and sexual complications in multiple sclerosis. And I will, in each of those, I will kind of highlight, where some of the other things kind of come into play. Because what I always say is your pelvic floor had a life prior to you getting diagnosed with MS. So whether, as I mentioned, whether you've had a baby, whether you have had prostate cancer or benign prostatic hypertrophy, any of those things can cause, basically MS then compounds those issues. So bladder issues, though, will be experienced by up to 96% of patients with MS, regardless of gender. So this is why with our MS docs that I work with throughout Columbus, we really encourage them to ask their patients at every single checkup, is there any change in your bladder? Because whether that's you're going to the bathroom more often, or you're having some sort of leakage, or you're getting up in the middle of the night and you never used to before, all of those things are cause for concern. So any change in bladder function, you should be reporting to your neurologist. Now, they might choose to send you to a urologist, so they might choose to send you to somebody that specializes in bladder function, and they may, on top of that, choose to send you to a pelvic floor physical therapist like me. The thing that we see is that often these bladder issues are not reported until up to 10 years after the first evidence of disease activity. So at this point, if you haven't, reported any of those bladder symptoms and you've gone on with them for that long, a lot of times you've developed a lot of compensations or bad habits surrounding those bladder issues. So we really encourage you that as soon as you start to see a change in your bladder function, you let your neurologist know, because then they can make sure that they're referring you to somebody that can help either fix that bladder function or make it so that you're not compensating and causing more harm. The most common complaints that we see in patients with MS include urgency, which means you feel like you got to go to the bathroom and you feel like you got to run there. Now, urgency can be accompanied by incontinence, or it can just be that you have that really strong, uncomfortable urge. So like, even if you try to delay it, you can't delay it. It doesn't feel good. Frequency is another one. So frequency means you're going to the bathroom more often. So normal number of times for peeing during the day is anywhere between 7 and 10. So usually it's normal to go to the bathroom every 2 hours or so. So if you're going to the bathroom, or you feel like you have to go to the bathroom every 30 minutes or every hour even, that is cause for concern, and we should look into that. And then the last one is urgent incontinence, which I kind of mentioned already. So you really have that urgency, and then you feel like you have to run to the bathroom, and then while you're running to the bathroom, you're leaking. Or another way we describe this is something called key in the door syndrome, or I call it garage door syndrome. Like, you're fine until you get home and the garage door goes up, and then all of a sudden you pee your pants. And that's just because your brain is telling your bladder, like, we're almost there, let's go ahead and do it, and you have some incontinence. So other complaints that we might see, they might not be as prevalent as the ones that I just mentioned, include hesitancy, which is where it takes you a minute, you sit down on the toilet and it takes you a little while. Interrupted stream, meaning you pee and then it stops and then it starts again. Incomplete emptying, where as soon as you think you're finished peeing, you get up and a couple minutes later you feel like you have to go again. Double voiding, so you have to like pee, stand up, sit back down, and then you can pee again. Nocturia, which means you get up more often in the middle of the night to go to the bathroom. And so what's important to note about this is it is normal to get up one time a night. If you're over the age of 65, you get a second one. So it's normal to get up 2 times a night if you're over the age of 65. But if you're getting up more than that, that is cause for concern. Either we are concerned about the fact that you're not sleeping well, or we're concerned about what your kidneys are doing at night. And then the last one is enuresis, and this is that you actually are leaking. So maybe you're not waking up, but in the morning you're waking up and you're wet. Either your sheets are wet, or if you're wearing a continence product, that is wet. So again, all of these are cause for concern, and you want to make sure that you are reporting these to your physician. So the hard part is that you can't really rely on just, kind of what you feel. Only 47% of patients with a high post-void residual, and what that means is that you pee and then there's still a lot left in your bladder, actually report feelings of incomplete emptying. So we know that MS wreaks havoc with your sensory system, that you get lots of different feelings. And so sometimes you can't always trust it. And so one of the other things that your neurologist may do is do what we call a post-void residual ultrasound during your appointment. So what that is that you go to the bathroom, and then right after you go to the bathroom, they scan your bladder with an ultrasound unit, and they look to see if you have this high post-void residual. If you do, that's going to be a referral to a urologist, again, to look at why you're retaining urine. There's also greater disability in recent relapse are associated with increased odds of being bothered by bowel and bladder symptoms. So what that means is that whenever you have a relapse, it is very normal for your bowel and bladder symptoms to get a little worse. What we get concerned about is that after the relapse is over, or if it calms down, we should see that those bladder or bowel symptoms get a little bit better. And if they don't, again, then you need to come see me. And as I said, that PVR might be the only test that most neurologists will do with their patients. So moving on. So what I'm always trying to figure out as a physical therapist is the bladder dysfunction a product of the muscle, which is my bag, that's what I'm treating, or is it what we call visceral, meaning that it is primarily an issue with the organ itself. So if it is muscle, I can treat it. So these are things like stress urinary incontinence, where you cough or you sneeze like I just did, and you leak a little bit. That's stress urinary incontinence, meaning that the muscle can't resist that extra pressure that's coming down on it. We can sometimes help with urge urinary incontinence, even though that is mostly a functionality of what's happening with the bladder. We can help decrease that a little bit. If patients are experiencing bladder pressure, meaning it feels really heavy in there, or what we call prolapse pain, which is something that women will get sometimes after having a baby, where they feel a lot of pressure in their pelvis at the end of the day. The things that I can't treat, that the urologist will likely treat, are things like pure urgency, meaning that you feel like you have to go to the bathroom and you don't necessarily leak when you go, but you just feel that urgency all the time. That's caused by your bladder contracting too often when it's not full, and is often most helped by medication. Sometimes urge incontinence I can't treat. Full pelvic organ prolapse, I cannot. So pelvic organ prolapse happens when everything gets too stretched out. And unfortunately, the skin around the vagina especially, it's like a rubber band. Once you have stretched it out beyond its capacity, it's not going back. And so that's more of a surgical case when that happens. And then I can't treat urinary retention. So that's when your bladder is no longer contracting. It has lost the ability to contract. And likely what that is going to lead to is clean intermittent catheterization. So having to mechanically empty your bladder because your bladder can't do it on its own. So let's move on to bowel dysfunction and talk about a couple of the issues that can happen with your bowels with MS. So the most frequent bowel dysfunction that we see with MS is constipation. And constipation can be kind of defined as a couple of different things. So most often people will define constipation as I have to strain really hard when I'm trying to poop, or that I go many, many days without pooping. But we as medical professionals actually add another definition to that, and that's the consistency of your stool. So meaning I want to know what the shape of your stool is and what it looks like. So don't be surprised if your pelvic floor therapist asks you that. But so, you know, if it's little itty bitty round balls that look like rabbit pellets, that means you're constipated, even if you're going every single day. So we kind of add that little bit of a definition on there. So bowel dysfunction most often happens, though, due to behavioral issues. So this is one of those things that I often say, really, your constipation has nothing to do with your actual MS, and everything to do with kind of your general behavior, what you're eating, what you're drinking, and kind of what you're doing throughout the day. The top 2 reasons why you have constipation are that you're not drinking enough water and eating enough fiber, and you're not moving enough. Our bowels really like movement, and so if you're not exercising, or if you have slowed down a lot from the exercise standpoint, then you're most likely going to have constipation. But there's 2 reasons why we have constipation. So the first one is called dyssynergia, and that's where when you try to bear down and you try and push the poop out, your muscles are not necessarily doing what they're supposed to be doing. They're not relaxing and opening up. And so that's where we as pelvic floor physical therapists come in, because we're gonna help you to be able to relax those muscles and push that poop out. And the second type is slow transit, and that's kind of what I just alluded to, in that if you're not drinking enough water and eating enough fiber and you're not moving, our gut actually slows down and doesn't push things through fast enough. And so what we do from a physical therapy standpoint is we try to make sure that, you know, you're doing what you need to do from a diet standpoint, and then you're also moving enough. If constipation gets really bad, it can lead to something called an impaction. So this is when constipation hangs around for too long and that stool starts to really back up. And it gets to the point where it will not come out. So it just kind of gets stuck in the colon, and that's when the colon is impacted. Coupled with pelvic floor weakness, it's really hard for patients to evacuate that stool. And if you get an impaction, something has to happen to manually flush that impaction out. Sometimes it's enemas, but if it gets really bad, that can lead to the need for bowel surgery to clear out that impaction. So we want to avoid those. All right, and then last but not least, I want to talk about sexual dysfunction before I talk about PT and how we fix all of this. But I think it's always important to note sexual dysfunction, because we want you to be able to participate in all of your activities of daily living, and that means being able to have sex if you still want to. So some of the factors that affect sexual functioning in MS. Fatigue is usually the biggest one. When people are super tired, nobody wants to have sex. And so, you know, one of the things that we talk about is that energy conservation and trying to plan some of your sexy time around when you feel the best. I know that's not the most spontaneous, but it's definitely something that you need to think about. Spasticity can hinder the positions that you might get into from a sexual standpoint, as can pain. Bowel and bladder dysfunction is another big predictor of sexual dysfunction, because no one wants to pee or poop when they're having sex. And then also mood disorders. And this is just because if you have depression, a lot of the medications that we put you on for depression can hinder your libido and hinder your wanting to have sex. The incidence of sexual dysfunction in MS ranges from 62% to 83%. So sexual dysfunction in men with MS, we see that erectile dysfunction occurs in about 70% of men. The mean time between the onset of MS and erectile dysfunction is usually about 9 years, but it can happen anytime along the disease process. The ability to sustain an erection is largely dependent on what we call psychogenic erectile drive, meaning that one, you actually like the person you're having sex with, and two, you don't have all of those other things that we just talked about. For men with sexual dysfunction with MS, Viagra is the most common treatment and may be given by either your urologist or sometimes your neurologist. When it comes to sexual dysfunction in women with MS, unfortunately, there's very few treatments for women with sexual dysfunction. A couple of the reasons why, though, you might have sexual dysfunction, one is diminished lubrication. And that is something that we can do something about. So for women, this might be because we've gone through menopause, and so we have less estrogen in our bodies. which can lead to diminished lubrication, or we might just need to use a little bit of outside help with that. Sometimes it's sensory disturbances. So I do have some patients that just have some numbness. That's a little bit harder to work with, but sometimes by changing positions or changing different stimulation methods, we may be able to help with that. Botox for bladder dysfunction has been shown to improve sexual functioning as well, but that's just because the women in the study were less worried about having a urinary accident, and so it helped improve their sex life overall. So what does a physical therapist do when it comes to treating some of these issues with whether it's bowel, bladder, or sexual function in patients with MS? The first thing we will do is we will do a very detailed subjective history. So when did the symptoms start, prior to the diagnosis or after? Because if they started prior to your diagnosis, they may be due to something else. And so we're going to then try and dig a little bit deeper into that. What are your primary symptoms? Is it more urgency, frequency, constipation? How are you dealing with your symptoms? So again, urgency or leakage, does that mean you're going to the bathroom a little bit too often? Or are you restricting your fluids, which is also not great for you? What medications are you on for your MS? Because some disease-modifying therapies are a little bit more bladder protective, and then other ones actually can make bladder symptoms worse. And then what medications have you tried in the past for your bowel and bladder symptoms so that we don't reinvent the wheel? Next, we will, as far as treatment goes, we may do a bowel and bladder diary. So this is not like Dear Diary, today my bowel felt happy. What this is that we take usually 3 days for your bladder and a week for your bowel, and you just write down every time you pee, every time you have urgency, what you have to eat or drink, and then for the bowel, every time you have a bowel movement and what it looks like. And then that helps me as the physical therapist to really kind of look at, okay, is it behavioral? Is it muscular? What's going on here? We also want to know kind of how much time are you spending on the toilet? How aware are you of your need to go to the bathroom? Do you have any difficulty wiping? And maybe that's why you're having some leakage. And do you have any urgency? So this is what the bladder diary might look like. Just again, there's a lot of different forms that it can take, but it's trying to get that information down. We do a lot of education from a PT standpoint. So some of it is on food and fluid management. So how much water is normal to drink? You'll hear lots of different people say lots of different things about how much water you should be drinking. I like to say between 48 and 64 ounces. So between about 3 and 4 bottles of water a day is a good kind of benchmark. And then I want to know if you're eating fiber. So you got to eat some fruits and some vegetables. You got to eat something that has some fiber in it in order to keep those bowels moving. We might do some manual therapy interventions, and what that means is I might do some bowel massage. I might do some different techniques to stretch out some of those muscles with spasticity so it's easier for you to urinate and defecate. We may be doing therapeutic exercises. We do Kegels, but that's not the only thing that I do. That would be real boring if that's all I did. We might be looking at your mobility. So are you leaking because you can't get to the bathroom fast enough? And maybe we need to look at getting a wheelchair for you. And then if you do have really severe constipation, we might look at something called transanal irrigation, which is generally, it's just an easier enema for you to do to clean yourself out on a weekly basis. So this is just a picture of the abdominal massage that I might do, just following the path of the colon, and it helps a lot with constipation, and it's something that I teach most of my patients. We also talk about toilet positioning quite a bit. With toilet positioning, so we want to put your muscles in the the easiest position for you to be able to defecate. So getting your feet up on a stool or on a small ledge may help you to be able to more effectively bear down and relax those muscles. So you may have seen the squatty potty. That's what this is showing. And then we do Kegel exercises. So I teach my patients Kegels, but we also teach a lot of core stabilization exercises for you to be able to contract and relax your belly muscles. We look at improved pressure management, so being able to bear down a little bit more effectively, and then finally some breathing exercises. We may do some modalities like e-stim. We may do something called biofeedback, or we might actually use an ultrasound machine for you to be able to see what your muscles are doing. So all of those are common modalities that physical therapists might use. So that was basically my intro to pelvic floor physical therapy. I will be happy to take any questions at this time.
Thank you very much, CARINA.
Thank you.
All right, we're going to take questions from the online audience first, and then we're going to switch to those that have questions that are here live, all right? First, from online, what can they do if you're leaking at some time during the night?
So if you're leaking at night, there's a couple of things that we try first. So first and foremost, we want to start limiting fluids about 2 hours before bedtime. So if you have to take medications right before bed, you absolutely can do that. But you want to try and decrease the rest of the fluids that you're having. The other thing is if you have a lot of leg swelling, putting compression stockings on about 2 hours before bed will push all of that swelling out so that you can pee before you go to bed. And then sometimes elevating your legs too will also help with that. If those things don't work, then you want to make sure that you are going to see a urologist, because it may be a problem that you need a little bit of medication for your kidneys.
Great, thank you. Can a neurogenic bowel be the main reason for chronic pelvic floor pain?
It can be part of the reason, but if you do have chronic pain, I highly recommend you see a pelvic floor physical therapist, because that can also be due to your muscles. And then that may decrease, or that we can help decrease that and help to improve that.
Okay, thank you. Next, since the colon and constipation can affect urination, can self-evacuation of the colon be useful?
So using like an enema or digital rectal stimulation can sometimes be helpful, but the other thing that we talk about is we need to figure out why your colon's not evacuating. So is it that your muscle isn't pushing as well? Is it that you have that slow transit constipation? So while that can help, it's not something that we want to rely on completely, and we want to get to the bottom of why that's happening in the first place.
Okay, next one. Person writes, they have a suprapubic catheter with a lot, and they get a lot of infections. What could you recommend to decrease the infections?
So sometimes that's a conversation with your urologist. Being really careful about clean technique. So when you are cathing yourself with the suprapubic catheter, maybe using gloves may cut down on infections. Making sure the area around it is clean, and then if you're still getting a lot of infections, again, that's a talk with your urologist. They may want to put you on like a low dose antibiotic to help decrease that a little bit. Okay, thank you. Last one from online, then I have other questions that people wrote in and gave to me. Have you noticed inner sphincter difficulty relaxing with bowel movements? Yeah, Yeah, so that's something that we can help with pelvic floor PT. Sometimes because you have spent so much time pushing and straining to get that stool out, that muscle doesn't want to open up anymore. And so we will work with you on helping to be able to relax that muscle a little bit more in order to be able to push that stool out. So that's definitely something that a pelvic floor physical therapist can help with.
Okay, thank you. Let's see, a question we have here is, does anyone have experience with Pure Wick at home or suggestions for nighttime bladder control?
So the Pure Wick catheter, it's a newer catheter for women. It's something that we use in the hospital, but I don't usually recommend it for home use all the time, just because it does increase your risk for infection, urinary tract infections. So what we usually say is, if you're going to use the Pure Wick, we definitely recommend that you don't put it in until right before you're about to go to bed, and that you need to get up and first thing in the morning and take it out, and then clean yourself really well, just to ensure that there's not any residual urine left around your urethra that could cause infection.
Okay, thank you. Last one. What have been the most promising effective therapies for bladder control?
Yeah, so there's a couple of things. So obviously, one, I'm going to toot my own horn, but pelvic floor physical therapy. So strengthening those muscles, really getting your habits down, and making sure that you're able to control the pelvic floor muscles and the abdominal muscles. For overactive bladder, one of the more promising things is something called InterStim, where basically they put a bladder stimulator in. Now, they used to not be able to do this for patients with MS because the stimulator itself and the tines were actually metal. So they were not MRI compliant. You need to get a lot of MRIs, so it was really difficult. But Medtronic is a company that actually came out with a stimulator. They listened to us saying that this was helpful for our neuro patients, but not able to be used. And so Medtronic created this stimulator that is MRI compliant. So that is an option. Urologists will put it in. They'll do a trial before they insert it into your body and do the surgery. And then if it's successful, then they'll go ahead and do the surgery. They generally last about 10 years before you'd have to get it replaced. And that's probably one of the more promising things for overactive bladder that I've seen.
Hi, what are your thoughts on the products they have for women now, like Anovo, and their shorts you wear to do the therapy?
Yeah, so I'm not a fan of the Anovo shorts. I tried them myself, so I always try before it doesn't contract your pelvic floor muscles. It contracts your abdominal muscles, which can actually be harmful. So, and then there's another one that's on the market that you insert in vaginally. It will help you find your pelvic floor muscles, but I highly recommend, if you're going to use something like that, you go see a pelvic floor therapist, and we can help you figure out the correct intensity to put it on so that you don't hurt yourself, and make sure that it's lined up correctly. So they can be helpful, but it does not replace pelvic floor physical therapy.
Hi, CARINA. Thank you for your presentation. Can you tell us how to find a neuro PT that specializes in pelvic floor?
That is a great question. And part of the reason I'm not there is I'm also teaching today a class to pelvic floor physical therapists about neuro. The best way to find a therapist is if you go to the American Physical Therapy Association. There is a find a PT option for consumers. So going to that website, it's apta.org, the American Physical Therapy Association. You can find, and we have self-reported specialties. So that is the best way to find a physical therapist that you can see for these pelvic floor issues.
Thank you very much, CARINA. We are finished with questions, but you can't see me. But I'm going to tell you what you're going to be missing, all right? We have a plaque that I'm holding up that we will be mailing to you, all right? It's thanking you for being a presenter here today. Oh, there you go. All right, now you could see me.
Thank you. I appreciate that.
Thank you. Awesome. Thank you very much, CARINA. We'll speak with you soon, okay? Plus, I just want to again thank all the supporters who I mentioned earlier. I'm not going to say all their names again. And I do have to thank greatly Orlando Production, my production team, who follows me around the country as we do all of our programs, handles everything virtual. And as you can see by all this equipment, it takes a lot to do all of this. All right, so let's welcome and say thanks to Orlando Production. And also, I have to thank all of you, all right? All of you online, thank you. All of you that attend our programs, thank you, because I couldn't do this if we didn't have people to do it for, right? So I do want to thank you all. All right, that's it. It's a wrap. Say goodnight, everybody.